So the respiratory system. So the function of the respiratory system is for you to respire, or for you to breathe. So this whole chapter is going to be taking in oxygen and getting rid of carbon dioxide. I do want you to also know that as we go through this, you do keep some levels of carbon dioxide because that works as a pH buffer in your blood. So we do keep carbon dioxide to create bicarbonate. Your respiration also has a huge impact on your olfaction, which is smelling, and then speech. So the way you force air out of your lungs. We have the two types of respiration. So you have external and internal respiration. External respiration is between your lungs and your blood. So bringing air in from the atmosphere and putting it into your blood. Internal respiration is from your blood to your tissue. So it happens deep inside your tissue. So external respiration is you come into contact with the environment, and internal respiration is down in your tissues. So pulmonary is talking about going into the lungs. And transporting blood is just transporting oxygen and carbon dioxide is actually in the blood itself. The major organs of the respiratory system, and we're going to go into each in detail, but the nasal cavity, the pharynx, the larynx, the trachea, the bronchi, and all their branches, and I have a quick little I'll write on it, and then the lungs and the alveoli. So here's a good diagrammatic representation of the respiratory system. This right here is the diaphragmatic muscle. So this muscle is what pulls down when we talk about our diaphragm. It also separates those cavities from your abdominal cavity. So we'll go through each structure of the respiratory system, beginning with the nose. So the purpose of the nose is a pathway for air to make it from the environment into your lungs. So I feel like everybody kind of gets that. But we want to breathe in through our nose because our nose also has a mucosal lining that warms and humidifies the air before it hits our lungs. So whenever we say breathe in through your nose and out through your mouth, it's because it's actually filtering and humidifying that air before it hits our lungs. This is a good diagram of the nose. This is showing you that the nose is the part of the nose that you can actually touch and interact with is mostly cartilaginous. Your nasal bones are up here, so all of this is cartilaginous. That's what that's showing you there. The nasal cavity is lined with the olfactory epithelium. We already know olfaction is smell. Epithelia is just the epithelial tissue. So these are mucous membranes that are helping to hold on to the odorants that are allowing us to smell. So it's a sensory nerve, sensory receptors. It also mentions, and this is the only other thing I'm going to point out here, that this is lined with pseudostratified ciliated columnar epithelium. What does pseudostratified mean? It looks like it's multiple layers, but it's just one. Columnar tells me what? It's the column-shaped cells, and ciliated means it has a little cilia. And cilia are used for movement, not absorption. Villi and microvilli are for absorption, but cilia is for movement. Okay, so we have a good looking nasal cavity here. And in 01, I kind of showed you the frontal view, and it kind of looks like Christmas trees so that it can create that turbulence. And those aren't just flat. Those are actually rounded so that the air kind of goes through this turbulent action as it goes through your nasal cavity where it's warmed and humidified before it hits your lungs. Here it is on a cadaver. Always just a little bit more gross when you're not expecting that. Okay? It's whatever. Here's where it tells you that the nasal cavity, which has the inferior nasal conch, which are those little rounded areas, help to filter, heat, and moisten the air. So that's the physiological function of your nasal cavity. During exhalation, those same structures try to reclaim that heat and that moisture before you exhale. Try to. Not always successful. Your sinuses, we know that all of our sinuses are in this area. The purpose of a sinus is it's a hole that lightens our skull. We talked about that when we talked about the skeletal system. So lighten the skull, it secretes mucus, and it helps to warm and moisten air. And they don't have a diagram of your sinuses in this chapter like they did in the previous chapter. Rhinitis, we know itis means that it's an inflammation of... So the problem with having an inflamed nasal mucosa, or the nasal cavity being inflamed, is it swells up, because that's what inflammation does, right? We just talked about it in the previous chapter. But those passageways become obstructed or occluded. So they're stopped. So you're trying to breathe, and you can't because it's so swollen. So a lot of times when that happens and we have that inflammation in our nasal cavity, we start breathing through our mouth. Like they'll be a mouth breather for that reason. Okay? The pharynx is the next structure. The pharynx is a tube that is part of both the respiratory and the digestive system. So we're going to see it in this chapter, and we'll see it in the next chapter as well. There are three sections of the pharynx: the nasopharynx, the oropharynx, and the laryngopharynx. So it's just kind of going down based on its location. Same structure, just where it's located. So it's the nasopharynx when it's in with the nasal cavity, oro here, and laryngeo there. Okay, the nasopharynx is where we can find our pharyngeal tonsil, which is also called our adenoid. Was it on this picture? Yeah. So here, your adenoid is back there. So a lot of times you think of your tonsils as just being right in the back, but they're everywhere. Okay, and I think we didn't talk about tonsillectomy in the last one. Okay, no, that's it. Okay, so the pharyngeal tonsil being your adenoids, and then within the same area, this is not a tonsil, but we have the pharyngeotympanic tube. And we talked about that with special senses. Remember, that was that tube that drains all of that into your stomach, your earwax, and all that goes there. We talked about that. So that's located there in that nasopharynx. The oropharynx, we have the palatine and the lingual tonsils, so two other sets of tonsils. And then the laryngopharynx is as we get a little bit further down. This is where it has to decide, is this going to go into the esophagus, or is this going to go into the trachea? Okay, if it's going to the trachea, that's respiratory. If it's going to the esophagus, that is digestive, right? And the mediator, what's deciding which goes where, is the epiglottis. And it's going back and forth trying to tell you where it needs to go. The laryngopharynx, by no surprise, is stratified squamous epithelium. Stratified means it's multiple layers. Squamous of the single pancake, flat pancake type cells. And that's because it goes through a lot of wear and tear, so those cells kind of fall off, and we don't have a damaged area. So same diagram there. Where we're at right now with the laryngopharynx, this is the epiglottis. In the event that we're bringing in air, that epiglottis will stay up and allow for air to come in. If we're taking in food, then it'll slap down and it'll direct it down the esophagus. And we talked about, I'm not sure if it was in the 1 or 2, that when you're laughing and eating at the same time, that epiglottis is like, what do you want me to do? What do you want me to do? So a lot of times you choke because the food gets caught in the airway and so on. Okay? Or like you're breathing while you're eating, and so you burp, which is why all that happens. Okay? So now we're into the larynx. So this is telling me that we're no longer in the laryngopharynx, we're a little bit lower, now to the larynx. The larynx is also called a voice box. That's usually how people reference it. In this area, we're going to the respiratory system. It's going to be anterior. So right here, where you can touch, this is your larynx. Okay, you can't physically touch your esophagus because it's posterior, but it's directly behind it, immediately posterior to the larynx starts your esophagus. Okay, and so this is the airway, the pathway for the airway, and it houses your vocal cords. There are 9 cartilages in your larynx because your larynx technically can't be bone. Well, I mean, it could be, but if it was, it wouldn't be flexible. And in the event that something got stuck there, it would be very difficult to get it out and manipulate it. Even now, sometimes you swallow like pills, and you can feel it, and it feels like you feel it right here, but it's technically in your esophagus, and the esophagus is kind of pushing up, and that's why it feels that way. It's not technically stuck, if you give it a little bit of time. Now, if you accidentally swallow a pill into your, that's a totally different thing. If it made its way into your larynx, then it's on its way to your lungs, that's an issue, and you're probably choking, and that's a problem. But a lot of times when you feel it, you're like, oh my gosh, I feel like it's just stuck right there. It's technically in your esophagus. The main piece of cartilage, besides the thyroid cartilage, which is what makes your Adam's apple, or is prominent with the use of testosterone, so it kind of sticks out a little bit further, is the epiglottis, and we've discussed that already. So here is the laryngeal cartilage, and that's what gives us our Adam's apple. These cartilages right here, and I'll show you in a future diagram, are not actually completely round. They're what we call C-shaped cartilages, and we want it this way because it keeps our trachea open, our larynx and then our trachea open so that air can go through it. If they were completely circular and something got down there, there would be no room and it would be very, very difficult for things to pass through. And I'll show you, the diagram I'm going to show you actually has the esophagus in it. So here, you can kind of see these cartilages aren't continuous. So here, right here would be the, actually, I'm on the wrong side. Right here would be the esophagus, and these cartilages aren't continuous. They would be here right at the end. Then we have our prominence, we have our epiglottis here, coming back. Oh wait, I was right. Look at me looking at this backwards. Sorry. Yes, so your esophagus would be right here, because here's your Adam's apple right there. Good deal. Just need to look and see what I'm doing. I'm alive. Here it is on a cadaver. Very appealing. Look at that epiglottis up there. Doesn't look anything like that. Anyways. Better view. Your vocal ligaments. Your vocal ligaments are what we call your vocal cords. Yes. Alright, so your true vocal cords are actually the result of glottis. So there's the epiglottis. Epi tells you it's on top, and then the glottis is actually where your vocal cords are, and they're opening and closing. I'm going to show you what that looks like. So here is the epiglottis, and this is going a little flapper. But here is my trachea, and this is, or my larynx. I said my trachea again. I apologize. My larynx. These are my vocal folds. So when I force air out, they open, and those vibrate. So those vocal ligaments vibrate. The amount of air, the force at which I push that air out, changes what my voice sounds like. If something is there and it obstructs that, it'll mention that here in just a few. So that's your glottis, and then epiglottis. So the glottis is where your vocal folds are, vocal cords. Here it says it right here. Voice production is how much air, how fast you're pushing it out, like if you're versus you're forcing it out and creating a louder sound. The words, the fact that you can say words is a result of not only the air, but how you shape your muscles in your mouth and in your tongue. Those are how we form the words that we say. A lot of times people with speech impediments can't manipulate their tongue enough, so they say things a different way or kind of talk with a lisp. Valsalva's maneuver. Valsalva's maneuver, I don't think, maybe we did mention this in 01. But Valsalva's maneuver is that maneuver that you make whenever you like lift something, you kind of hold your breath, or when you poop, or you're trying to push a lot of pressure. So you close your glottis and you force air into your abdomen. So that's that Valsalva's maneuver. So that's what that's referencing here, where your vocal folds function as a sphincter. So they close and you put that pressure down in your abdominal area. So it happens when you're lifting weights or perhaps you're using the restroom. Now, under or inferior to the larynx is the trachea. And again, I said it twice incorrectly, but the trachea has three layers. The mucosa, submucosa, and the adventitia. The mucosa is going to be in the center. Then the submucosa will be around that. And then the connective tissue, the adventitia, will be on the outside. So it goes mucosa, submucosa, and then adventitia, the connective tissue on the outside. Here's the diagram that I was talking about that I really, really like. So first of all, you can see these tracheal cartilages. They're C-shaped. They're not a complete circle. Here, right here, is the esophagus that's immediately posterior to the trachea. You can see that there's a little room where it can move back and forth. So like when you swallow something and it needs to expand, it can kind of push into that area without obstructing anything. You can also see that this mucosal lining is lined with cilia, so that and it'll have mucus there as well, because I'm sure we're about to see that. And it'll help catch pathogens or any type of debris or antigen as it comes in. The lumen of the trachea, the lumen of the esophagus. But this is a really good picture showing you those C-shaped tracheal cartilages. Here's an up-close photomicrograph of it, so you can see the mucosa, submucosa, and then the connective tissue on the outside, the three layers of the trachea. Here's the cilia up close. It is super cool. I know that you're probably not as excited as me, but that is cool. Okay, these next few slides go through the pathway of air through your lungs. Okay? So I normally have a big board like this, but I can't move the camera to do, so I have put it in a list form so that you can learn the order in which airway the air travels through. So you have the right and left lung, and we're going to get through that in just a moment. But we start with the main bronchioles or main bronchi, sorry, main bronchi, and that's going to be right and left. And then we go to the lobular, or lobar, I always add extra syllables, bronchi. And I'm going to put right here, you have 3 on the right and 2 on the left, because your left lung only has 2 lobes, and your right lung has 3 because your left lung has been displaced by your heart, because your heart's a little asymmetric there. Then from your main bronchi to the lobar bronchi, then you go to the segmental. So it breaks itself into segments. Segmental bronchi. And then it goes to the bronchioles. Or some people call those bronchioles. I just call them bronchioles. From the bronchioles, it goes further to what we call the terminal bronchioles. And then to the respiratory bronchioles. And then to the alveolar duct. Alveolar sac. And then the alveoli. Your air has a lot that goes through a lot of pathways. And so this is what we would call the conducting zone. So this is getting air to your air sacs. This is conducting. And this right here is respiratory, which is where you're actually breathing and gas exchange is actually occurring. Okay, so we're getting the air down there, and then gas exchange occurs in the respiratory area. If the next few slides have all of this in a paragraph form. And so I just organized it so you can see it goes here, 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 because then that helps you with the memorizing and the studying. But it tells you that we start with the bronchioles, okay, the right and left main bronchi, and then they turn into the lobar bronchi. And then from there they go to segmental, and then to the bronchioles. The bronchioles then turn into the terminal, so those are the end of the conducting area, and now we go into the respiration. So here's your trachea, and then here would be your main bronchi, and you can see it goes to both lungs. Okay, and then you would have your primary, which is your main, secondary, which would be the lobar, so it's going into each lobe, and then tertiary as it begins to segment. And these aren't really labeled to where you can see each of those, but you can, as we get in a little bit further, each of these bronchioles gets smaller, smaller, and smaller until we actually get to the air sac. So this gives you an overall look. This also shows you that you have the 3 lobes in the right lung and just 2 lobes in the left lung. And here's where your heart would sit. So that left lung is displaced by where your heart is. From the terminal bronchioles, we then go to the respiratory bronchioles. Respiratory bronchioles is where the gas exchange is going to begin to occur. So we have our alveolar ducts that will then turn into our alveolar sacs, and eventually our alveoli. This is the actual site of gas exchange, and we have a ton of capillaries here as well. And I believe there's a diagram that shows that, yes. So we have our terminal bronchiole, then it becomes respiratory, then we have our ducts, then we have our sac, and then you have your individual alveoli. These are your air sacs. Okay. Those are the parts of the lung that you can actually, where gas exchange actually occurs. This is showing you what they look like inside, so they're just hollow. They are literally simple squamous epithelia, so just one cell thick. And that's so that gas exchange can occur in an efficient manner. There are 2 types of cells in the lungs, 2 types of cells. You have alveolar cells, and you have surfactant for type 2 cells. So type 1 are your actual alveoli, and type 2 are your surfactant-producing cells. Your lungs handle a lot of friction. As you're breathing, you're inspiring, you're expiring, so on. There's a lot of friction that's generated from all of that movement. You produce a chemical called surfactant. And if you were to touch surfactant, let me kind of explain what it feels like so you can get it. If you know Dawn dish soap, and then you put like a few drops in like a cup of water, it kind of has that slight film where it's a little bit soapy but mostly water. That's what the surfactant is like. And it douses your alveoli because they're moving so much and there's so much friction, and it prevents them from damaging. In fact, surfactant is what actually stimulates the release of oxytocin, which allows for women to go into labor. When the baby begins to produce surfactant, that signals the mom that that baby's mature enough and ready to come out. Because that's the last organ system to mature, are the lungs, of course, because we don't use those in utero. This diagram I absolutely love because it shows all of the alveoli and it shows all the capillaries. So every single alveoli has a capillary bed there where oxygen is dropped off or taken into the blood, carbon dioxide is released back into the alveoli, and so that gas exchange occurs. It occurs at each individual alveoli. Of the duct itself, it's just like a hallway.
In between.
So here, like the duct is like it's bringing it in, and then this right here is the sac, and then you have the individual alveoli. So it's like a hallway that's kind of specifically. And when we studied duct in 01, a duct is something that has a specific destination. So if it's an alveolar duct, it's getting you directly to those alveoli. Here is just when you're looking at the blood vessels, the capillaries around it. So the alveoli removed. There's a diagram in here. I'll get to it. So here you have the individual alveoli. You can see that there's different types of cells. We have some macrophages. Why macrophages in the lungs? Right. When you're breathing things in, you're going to breathe things, and the mucosa may not catch it. So we need to get it taken care of before it makes it into your circulation. So we have macrophages there. We have our type 1, our type 2 cells, and you can clearly see we have plenty of blood flow. We have a lot of capillaries there. That's because this is where gas exchange occurs. When we look at the anatomy of the lung holistically, the apex of the lung is the top. So the apex of the heart was the point, and it was towards the bottom. The apex of the lung is the top, and the base of the lung is the bottom, where it was the opposite on the heart. The base was at the top of the heart, the apex was at the bottom. When we look at their placement, the part of the lung that's up against your ribs, we call the costal surface. Okay, because it's up against your intercostal, the ribs. Okay, the root is where the vessels actually branch into the lungs. Where are your lungs located? In the pleural cavities. And we discussed that in 01 too. You have 2 pleural cavities. Your lungs are not grouped together. They are completely separate from themselves and from all surrounding structures. So if one lung is damaged, it doesn't mean that both lungs will be. They are separate completely. Okay, you can kind of see that here, and you can also see the heart and its pericardium. But you can see the pleural cavity there. You can see the hilum, the area, the root where it's going into. So here's all the blood vessels going into that lung there on each side. Again, the apex, the base. The hilum is where everything goes in. Let me kind of show you here. So this area collectively, where everything is coming in and out, is called the hilum. The root was specifically talking about the blood vessels. So let me just distinguish between those. Okay? I already told you that the left lung is a little bit smaller than the right because it's displaced by the heart. So that little notch is called the cardiac notch in the left lung only. The right lung, so the left lung has 2 lobes, the superior and inferior. They're super simple as far as naming goes. Left lung is superior and inferior. With the right lung, there's 3 lobes. So we have the superior and inferior, and guess what we call the one in the middle? The middle. Thank goodness, right? And no fancy name. Sometimes fanciness is overrated. So we have this guy here in his lungs. Looks good. Okay, a nice looking lung. This whole area collectively is the hilum because that's where everything's going in. Okay, you can see here is the blood flow, and then here is the actual airflow. Okay, this is the diagram that I was referencing, or in my head I wanted to talk about, but I want to show you first. This is where they have taken all of this, extracted that, and colored it based on where this is incredible. This is actually, if you, and I had referenced Body Worlds previously, and they have this sitting there, like for you to like look at. You can't touch it because they don't want you to touch anything that's plasticide. But it's just amazing when you think about all of the different pathways. Like we learn it, like it goes from here and here to here. So people with a simplified mind like mine are like, no, turn right, turn right, turn right. Okay, we're here. This is crazy. Anyways, I get excited about stuff like that. Blood supply. Like more organized?
No, I would think it would be less organized.
Nice.
It would be hard
To distinguish between them?
to separate them. That had happened.
Well, in my head, I saw it as, it was like a right turn, like you had this direct. I didn't see it all spread out like that. When I saw it like that for the first time, I was like. But anyways, blood supply. This is talking about the blood flow through the lungs. This is not talking about the blood flow to the lungs. Okay, so we're talking about, this is what you and I have already discussed. So pulmonary arteries carry blood away from the heart and towards the lungs. That's oxygen poor blood. Remember, that's the exception. Pulmonary veins bring blood back from the lungs to the heart. Pulmonary veins bring blood back from the lungs to the heart. Okay, so they have oxygenated blood. Now, this is the blood flow that actually serves the lungs. So even though their goal is to provide oxygen and so on to the body, they also have to be provided oxygen. Okay? So they don't use what they process. Just like all the other organs we've discussed, like the vasa vasorum, the coronary vessels, they're a branch from the aorta. So they're a part of the systemic circulation. So the bronchial arteries are the arteries responsible for getting blood to the lungs, to actually serve the lung tissue. Okay? So, and it mentions here that they branch from the aorta. And of course, the pulmonary veins are going to take blood back to the heart and from the lungs. Not being processed through it, but serving it. Here, this is talking about the serous membrane. So we have the visceral pleura, the parietal pleura, and the pleural fluid. Visceral tells you it's located where? On the surface of that organ. So the very outside of the lung is the visceral pleura. The parietal pleura is a little bit off from it, and in between the two is the pleural fluid, and that helps to reduce friction. Okay, so just using this diagram, the visceral pleura here, parietal pleura here, and in between is the pleural fluid. We call those the pleural cavities. You have two pleural cavities for your lungs, one for each lung. Okay? Any questions so far in anatomy? Let's talk about physiology. Inspiration versus expiration. Inspiration is inhaling. Expiration is exhaling. But why can't we just call it inhaling and exhaling? So we're doctors. Okay? Ultimately, what gauges whether you're inspiring or expiring is pressures. So you're going to see two terms or two references. It's going to have a capital P, and then maybe not. Okay, well, see where it says P and then ATM? That's the atmospheric pressure. Here it is. Here's P and PUL. This is the pleural pressure. Pulmonary, not pleural. Pulmonary pressure. So the pressure inside the lungs versus the pressure in the atmosphere. And those two have to go back and forth, and that's how you inspire and expire. Atelectasis is a lung collapsing. A lung collapse could be for a lot of different reasons, and just because one lung collapses doesn't mean both will. If you watch a lot of crime shows, When people get stabbed in their lung or shot in their chest, they often suffer from atelectasis. So how do we fix that? We fix the hole, and then the lung will reinflate. So as long as that tissue is not damaged. Pneumothorax is where we have fluid or air in the pleural cavity. The problem with that is this. That cavity is around the lung. We're going to learn a term in a moment called compliance. Our lungs have to be very compliant, like they have to move back and forth. When we put pressure in that cavity that surrounds it, it decreases the compliance, so that lung can't move a lot. If you've ever seen somebody with pneumonia, when they try to breathe, it's like they're trying really hard because there's so much pressure against their lungs. They're trying hard to get air in. So it's reducing the compliance, not allowing their lungs to move as much. Inspiration versus expiration, we have volume changes and pressure changes when it comes to the gases. So, whenever you're inspiring, this is an active process. You have to you don't tell yourself to inspire, you have the medulla oblongata has your respiratory centers, and it's telling you need to inhale, you need to exhale. Exhalation is a very passive process, and it just, there's no work to it. But inspiration is a very active process. So it mentions here, you use the diaphragmatic muscle, has to contract, your intercostal muscle, is that right? Yeah, external. Intercostal muscles have to contract in order to allow your thoracic cage to increase. The volume inside your thoracic cavity increases. The pressure drops. And then I had said volume, was that the only two on the other side? Yeah, volume and pressure, okay. The volume increases, the pressure drops. Volume increases, pressure drops. So you're bringing in oxygen, the volume of oxygen increases, the pressure inside drops. Okay? Whenever you are carrying out or participating in any type of vigorous exercise or have COPD, and COPD is chronic obstructive pulmonary diseases or disorders. So that could be a lot of different things. It could be emphysema, it could be asthma, anything that you've had for a long time that's impacting how you breathe. This is a very forced inspiration. So when you're working out, you have to tell yourself, breathe, like you're making yourself breathe. And a lot of times if you stop breathing, you get lightheaded. Okay? If you have COPD, those people struggle breathing as well. So it's like a very forced, even though it's active, this one is forced. This is showing you the physiology of that inspiration. Expiration is usually passive, like I mentioned. Everything really just relaxes and air just passively flows out, or oxygen passively flows out. And it calls it air, so I want to make sure that I stay consistent. In this case, the volume decreases, but the pressure increases. So the volume decreases because the air is leaving, and the pressure inside is increasing because it's trying to help it move out. Okay? So when you're inspiring, the volume increases, the pressure decreases. You're expiring, the volume decreases, but the pressure increases. Okay? Forced expiration is a very active process, and when you force air out, you use your abdominal muscles to do that, and it mentions that here. Okay, so diagram for expiration. This is showing you the difference in inspiration versus expiration, okay? And showing you the differences in the pressure, showing you where it's measuring, using it pointing over there. As far as the volume of your breath, it's with the air, we're measuring the air in that volume, trying to put it in a container, okay? Physical factors that influence your ventilation. Airway resistance. And that's usually menial if we're healthy. But if you have some type of inflammation or something stuck down there, or you have a tumor or a growth, then that, of course, can increase resistance. Alveolar surface tension, that's that surfactant, and lung compliance. So 3 things that impact your ventilation, pulmonary ventilation. Airway resistance, I already mentioned. This is pretty insignificant unless you have something wrong with you. So you and I, as if you're a pretty healthy person, no emphysema, nothing like that, no asthma, no allergies right now, your airway resistance is pretty much non-existent. It's not difficult for air to make its way through your bronchioles. Okay, so it's showing you, I already mentioned the conducting versus the respiratory. Homeostatic imbalances for airway resistance would be some type of swelling or inflammation, so that would cause constriction or obstruction. Again, if you're perfectly healthy and able to inspire, then inspire like as in breathe, then you should be fine as far as resistance is concerned. In the event that you're having an asthma attack or an allergic reaction, we take antihistamines or even inject epi if it's extreme, like anaphylactic shock, in order to dilate all of that and dilate the bronchioles to decrease resistance. The second factor is surfactant. Surfactant, I told you, is that detergent-like fluid that your type 2 cells in your lung produce. And this reduces friction and allows for these cells to continue to function the way that they're supposed to without any type of distress or tension and tearing. This is an issue for babies who are born premature. A lot of babies that are born premature, their lungs are not fully developed, so immediately after birth, not immediately, but shortly after birth, they're injected with steroids that will stimulate the development of their lungs. But normally if you have a premature baby, we keep them in ICU or NICU for the extended time of your pregnancy. So if that baby, and we usually say 32, 34, 36 weeks, depending on the baby and if there's any issues. So if that baby's born at 26 weeks, we're going to keep them at the hospital for 10 more weeks to allow for them to mature and be able to carry out life functions on their own. All right. I think at this point, a 24-week-old baby is the youngest one that we've had survive. Before then, nothing's really developed enough that they can maintain life on their own. The third factor is lung compliance. Lung compliance is how elastic are your lungs? How extensible are your lungs? Because the more extensible, the more elastic they are, the more air you can accommodate. Okay? Compliance is decreased by poor posture. So like when you're slouching, your lungs can't open up as much as they can, as much as they should. If you have scoliosis or some type of condition that is causing you to lean a certain way, a lot of things like that will decrease the amount of movement of your lungs. Our ribs, when we learn the skeletal system, we have 2 floating ribs. These floating ribs are beneficial to us because if they did come all the way around, they would decrease our lung compliance. Our costal cartilage, the cartilage that's here in between our ribs and our sternum, the fact that it's cartilaginous increases compliance. If it was straight bone, we wouldn't have that flexibility that we have in order to increase the amount of air that can get into our lungs. So the higher the compliance, the easier it is for your lungs to expand. What kind of things diminish lung compliance? Posture, decreased flexibility. It says non-elastic scar tissue. If you have emphysema or you have some type of damage to your lungs and that tissue dies, that's going to once it dies, it doesn't do the inspiration expiration function anymore. It just sits there dead. If you've looked at a smoker's lungs versus healthy lungs outside of their body, not in their body, but you can clearly tell the difference. Smoker's lungs, the compliance is like this. A healthy lung, it's crazy. And the way they feel, the softness and the flexibility. Already said it. Okay, on these next 2 slides, it talks about specific volumes and capacities. You don't have to calculate anything. And I left it where it just kind of shows tidal volume, inspiratory reserve, expiratory reserve, and residual volume. Here are the capacities: inspiratory capacity, functional or residual capacity, vital and total lung capacity. But then I left this. I think there's one of them on your review, and that's the only reason I'm referencing this, because I don't have you calculate anything, but I think it references maybe total lung, I can't remember which one, but I felt like I needed to make sure I reviewed this with you real quick. But it has each of the volumes, and here are the capacities, and here's a description of what it is. So for example, here the functional residual capacity. Functional residual capacity is the end reserve volume and the residual, or expiratory reserve volume and the residual volume. You add those 2 together. So that's what that is and how to calculate it. Again, you won't have to calculate it, but I do believe there's one of these mentioned on the review. I just don't remember which one. Sorry. We won't go through this diagram because I'm trying to get us through as far as we can. Anatomical dead space is the part of your lung that's pretty much not doing anything. You can be perfectly healthy, but you still have anatomical dead space. So it mentions you have approximately 150 milliliters of air remaining in your passageways at any given time. So it's not 100% efficient. In fact, our bodies aren't at all. A spirometer, low-key, this is a breathalyzer. So you breathe into it, and if you've ever, there's a difference between, if you've done a breathalyzer before, it's very similar. But you have to expire until it's physically painful because it's measuring your capacity, how much that you can inhale or inspire versus what you can expire. If you've had to blow into a breathalyzer before your vehicle started, you're blowing like for 2 minutes, it seems like. You blow from beep to beep, and I know that because my sister had one for a long time. I would drive her car, and I freaking hated that because you would sit in the Walmart parking lot and hear, well, not gonna find it. And people were walking by listening to the beep, and I was like, they're totally judging me. But it's really difficult, and if you don't do it enough, the car won't start. So it's a lot of work to measure the capacity of your lungs. Obstructive pulmonary disease is just that, obstructive pulmonary disease. So there's some type of obstruction in my lungs, and it's causing disease. It could be a lot of things. Again, that could be emphysema. That could be a long-term inflammation like bronchitis. So anything like that could be considered an obstructive pulmonary disease. A restrictive disorder is anything that will decrease the total lung compliance. Anything that will decrease the total lung compliance. So it could be a disease, or it could be something physical. It's mentioning here fibrosis. It could be your skeletal deposition, the way that you're formed. You could have scoliosis or something like that. A wreck, something could change the way that your total lung compliance is effective. Minute ventilation is how much air passes through your lungs in 1 minute. I'm grateful that it's pretty straightforward. At rest, it's around 6 liters per minute. Whenever you're exercising, it could be up to 200 liters per minute, which is quite a bunch. Non-respiratory air movements are anything that you don't do or anything you do that doesn't necessarily impact your respiratory rate, so like coughing, sneezing, yawning, all of that. Those are considered non-respiratory air movement, or non-respiratory movements. Yawning, a lot of people pull in and say, hey, what's yawning? Yawning is usually a overwhelming amount of carbon dioxide, and that's usually because you get tired, so you stop breathing completely as deep as you usually do, so you do these shallow breaths. There's a buildup of carbon dioxide, so when you yawn, you're releasing all that carbon dioxide and trying to bring a lot of oxygen back in, and that's also, of course, a sign of us being tired, so that's what that is. Okay, I've already addressed these two terms, external respiration versus internal respiration. So external is between your lungs and blood, internal is between your blood and tissue. External respiration is impacted by the thickness of the respiratory membrane, so that's your alveoli, those air sacs, and the pressure, atmospheric and the pulmonary pressure. This is a term I brought up the last time we were together, ventilation and perfusion coupling. Okay, and here it's talking about the fact that your respiratory membranes are pretty much the same. They should be around 1/2 to 1 micrometer thick. That's super, super thin. Okay? As far as how much alveolar tissue you have, I don't know if you've ever heard this. This is a trivia question. But your lungs, if you were to spread them out, they would cover a tennis court as far as the amount of epithelial tissue that they contain because they're so folded. People think your lungs are hollow, but they're a steak. Like they're a thick, beefy steak. I think we have some over in the other lab. I hope we do, so I can get you to feel them. Because I usually, in my normal lab, I have a set of lungs, and I'm like, touch them, feel them, so you can get an idea of what lungs feel like. In the event that your lungs, you're suffering from emphysema and things like that, of course it's more difficult for a gas exchange to occur because that tissue is dead, or it might be a lot thicker. Okay, here it's just showing you at rest what that pulmonary circulation as far as the gas exchange is concerned would look like. showing you, depending on where you are in your body, where the how much oxygen, how much carbon dioxide, how much oxygen, how much carbon dioxide. Here we are in our tissues, oxygen and carbon dioxide. So you can see higher oxygen this way, and then we start to see slightly higher carbon dioxide levels as we get back. But even your red blood cells will bring oxygen back as well. Ventilation and perfusion. Ventilation is airflow, perfusion is blood flow. When airflow is high, we want blood flow to be high. When airflow is low, we want blood flow to be low. If there's a mix match, we have an issue, which is what we can see here happening on this slide here. So this is considered not a lot of ventilation, so low airflow. This is considered a lot of ventilation, so a lot of airflow. If I have low airflow, I want low blood flow, low ventilation, low perfusion. Okay? Here are the vessels. This is matched correctly. Low ventilation, low blood vessels. This is mismatched, meaning I am not bringing in a lot of oxygen, so I shouldn't have a lot of blood flow going through there. Here, I have a whole lot of oxygen all of a sudden, so I need to dilate my vessels so that I'm moving more blood through that area to pick up that oxygen. So we want ventilation and perfusion to be the same or equal. If they're going to be high, they're high. If they're going to be low, they're low. They should not be mismatched. Internal respiration is dropping off of oxygen at your tissues and picking up of carbon dioxide from your tissues and bringing it back into your blood. This is the same diagram from just a moment ago. Transport of respiratory gases, we have two, oxygen and carbon dioxide, the only two that we're discussing. For each hemoglobin, and hemoglobin is the protein found on red blood cells that transports oxygen. For each hemoglobin molecule, you should be able to carry 4 oxygens. If you're carrying 4, we call it saturated, and I'm positive that that's in the notes in just a moment. And if you're carrying less than 4, it's considered unsaturated. Okay? Oxyhemoglobin, and this was a previous term in a previous chapter, oxyhemoglobin means that that hemoglobin has oxygen on it. Deoxyhemoglobin means that it's dropped that oxygen off. I mentioned in the cardiovascular chapter that hemoglobin reversibly binds to oxygen, and that means it can pick it up and then take it somewhere and then just drop it off. Okay, so we discussed that. Yes, fully saturated is where you're carrying 4 oxygens per hemigroup. Partially is anything less than 4, so 3, 2, or 1. Partially saturated. What can impact the saturation levels? The amount of oxygen available, your temperature, your blood pH, the amount of carbon dioxide, and then right here it talks about BPG. This is a biological concept as well. This is if you are doing anaerobic activities, like sprinting, swimming, weightlifting. This is where you're going into anaerobic respiration. So all of these factors are taken into account whenever you're talking about how much oxygen you're carrying. Okay, so factors that influence the amount of oxygen that your hemigroups or your red blood cells are carrying. So here's a diagram just showing you that. So here is a hemoglobin molecule. This is partially saturated because it has 0, partially, 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 completely saturated because it has 4. Partial. Well, I mean, it's not carrying anything. So, but if it's anything less than 4, we call it partially. By definition, yes. Okay. So ultimately, it's and it's going to say this here in just a moment, that you want your hemoglobin saturation levels, your O2 level. This is what we call our O2 saturation, or our pulse ox levels. We want our oxygen levels to be around 98, 99 to 100%. And if you're monitoring them on a computer, those are the numbers that you're looking for. When it starts to drop into 96, 95, we don't immediately start worrying, but we're like, something's not right, because those molecules have no reason to not be fully saturated. And that's what it's referencing here. In the blood coming back, in the venous return of blood, we expect to see more carbon dioxide than we do oxygen. However, not all oxygen is always completely dropped off. So sometimes there's oxygen that's carried, just it makes a round trip. Okay, so and that's what it's referencing here. Here it's talking about the oxygen saturation levels at different elevations. So this is at sea level, and this is in the mountains where we're at a higher altitude, and we've already discussed the implications in red blood cell production It's associated with the fact that there's less oxygen available. And this is talking about the temperature and the pH and its impact on your saturation levels. So it's reiterating what was brought up on 2 slides before. Hypoxia. Hypo tells you what? It's low or lacking, yes. So hypoxia means that your oxygen levels are low. Inadequate O2 delivery to tissues. This causes cyanosis. What's cyanosis? The bluish-green coloring. And that tells us, when you're losing blood flow to a place, it starts to turn that cyanotic color. We already know blood is never blue. It just looks that way because it's oxygen poor. A lot of reasons that you can be hypoxic. Anemic hypoxia, it's because you don't have enough red blood cells. So if you don't have enough red blood cells, you're not carrying enough oxygen, so there's not enough oxygen in your tissues. Ischemic hypoxia, ischemia or ischemia, either way you want to say that, is because it's completely blocked or occluded. So something is there. Hopefully it's not in like the lungs, the heart, or the brain, because that's going to be a huge problem. And that can cause a cardiovascular accident or a cerebral accident, which is like a stroke. But if it's happening somewhere else, there's some obstruction there like a blood clot, it could keep blood from getting down to wherever its destination is. Histotoxic hypoxia. Histo tells you it's the tissue, toxic tells you something is bad. Oxygen levels are low usually because something besides oxygen is binding to that hemigroup. And we see this in like areas where you're not, what is it what they put over your mouth when they're stealing you? Chloroform. Yes, I was like, what is that called? I don't even know. But they put it over and it causes you to kind of, because
stealing you.
When you're stealing you, yeah. Whatever. Anyway, hypozemic hypoxia. This is because you have some type of pulmonary condition, so you have low oxygen levels. And carbon monoxide poisoning. Carbon monoxide has a higher affinity, or your hemigroups have a higher affinity to carbon monoxide versus carbon dioxide, but it's lethal to you, and that's why it kills you. Whenever we're transporting carbon dioxide throughout our body, when hemoglobin is attached to carbon dioxide, and this was in a previous chapter as well, we call it carb-amino-hemoglobin. Carb-amino-hemoglobin. We try to get rid of the majority of our carbon dioxide, and I mentioned at the beginning of this chapter, we do retain a little bit of it, and it helps us to buffer our blood pH. So we use it as a bicarbonate. Bicarbonate is our buffer for blood pH. So if our blood gets too acidic, we can release some bicarbonate ions, and it will help to neutralize it to bring us back to our homeostatic range. We see that a lot with people missing meals or working out really strenuously, and then maybe just drinking water, which is what they feel like they should do, but still that we see a slight change in their pH. So that buffer is there so it doesn't impact you and you don't suffer. This is showing you the diffusion rate. So right here, we have the actual tissue. We're inside that tissue wherever. And here is our capillary. So the oxygen from our red blood cells is going this way. The carbon dioxide from our tissue is going this way. So it's showing you that using those arrows. Diffusion by definition is going from a high concentration to a low concentration. And in this case, the carbon dioxide is going from a high concentration to a low concentration. And that's what this diagram is showing. Carbonic acid, so this is exactly what I was just talking about. I didn't know that there was a whole slide because I didn't get through all of these when I was studying for you. But this is talking about that bicarbonate ion and using it in the event that you have some type of excess acids for whatever reason, whether you haven't eaten or you've consumed something or you're having a problem within a metabolic problem within your body. Influence of carbon dioxide on your blood pH. So, too much carbon dioxide. How do we get too much carbon dioxide? We usually do a slow, shallow breath. Our poor posture, or as you're getting tired. Like if you're laying there and you start to take in, or you start releasing less and less carbon dioxide. When you have more carbon dioxide in your body, this drops your pH. When you get rid of too much carbon dioxide, that increases your pH. We want to keep our pH homeostatic because there's only two things that can really cause immediate denaturing. Temperature and pH. So we've talked about those previously as well. pH needs to stay homeostatic. So if it gets too acidic, I want to buffer it. If it gets too basic, I want to buffer it. I want to keep it in my homeostatic range. Controls of respiration. So this is where we get into the nervous system. We have ventral and dorsal. Do you recall the difference between ventral and dorsal? Okay, ventral and dorsal is front and back. Which one's sensory and which one's motor? So whenever information for respiration comes to you, it's going to enter the back of your spinal cord. So dorsal. Dorsal respiratory group is sensory. Ventral respiratory group is motor. Okay? So if there's damage in one of those, then it's damage on whether or not you sense it or whether or not you can breathe. And anyways, if there's damage in a respiratory group, you're probably on your way out. Okay? And I don't mean to say that in a mean way, but you're probably on your way out. Ultimately, again, the respiratory centers, just like the cardiovascular centers, are located in your medulla oblongata. Your ventral respiratory group, which is your motor portion, sets your eupnea. U means true. So this is your regular breathing rate, regular respiratory rate. So at rest, we're looking around 12 to 15 breaths per minute at rest. The nerve that helps to innervate and control this is your phrenic nerve. The phrenic nerve is attached to your diaphragm. And your diaphragm is the muscle that will contract in order to allow you to inspire. Okay, so eupnea on this slide, the major thing is your normal at-rest breathing rate, 12 to 15 breaths per minute. This is showing you the medulla oblongata and where your respiratory group is. Depth and rate of breathing, hyperventilation. Hyperventilation is where when you're breathing, you're not actually taking meaningful breaths. So your carbon dioxide levels decrease in your body. So how do they fix that? They ask you to breathe into a sac. When you breathe into a sac, the psychological aspect tells you that you're being fixed. But the physiological aspect is when you are exhaling, you're exhaling carbon dioxide, which we already know your body is lacking at this moment because you're hyperventilating. So when you do inspire again, guess what you're going to take in? Carbon dioxide. So that's why we try to get people who are hyperventilating to, we give them a bag, and psychologically it helps them relax, but physiologically it brings them back into sync. So it's crazy how when you think about that, how that impacts. Apnea is anytime you stop breathing. This, like when you have sleep apnea, this could be because while you're sleeping, like your tongue falls over your your trachea, or back over your throat is technically what it would be, and you just kind of gasp for air. If you do suffer from any type of sleep apnea, you probably sleep very poorly, and the people around you also sleep very poorly because you're snoring all the time. And people with sleep apnea, when they stop breathing, like they'll snore, then they'll stop breathing, and then you like hear the silence. You're like, okay, they're not snoring anymore, and then because their oxygen levels got so low because they weren't taking anything in, they were gasping. They felt like they were choking, so that woke them up. Mm-hmm. Yes, and so they don't sleep well because they continue to wake up because they're low in oxygen. The people around them don't sleep well because it's not a quiet process. Like when they're gasping for air, it's like, and you're like, oh my gosh, could you please stop? Okay, or wake them up. A lot of times have them sleep in a chair or something where they're more erect, so it's easier for their tongue to stay forward, depending on what's causing that apnea, if it is their tongue. Okay, so this is showing you the innervation of the nerves. Hypothalamic controls, your hypothalamus in controlling your respiratory rate, and it's going to impact right around that, remember, is your limbic system. So if you're excited, your respiratory rate will increase. If you're sad, it will be impacted as well. When we talk about cortical controls, where's the cortex that I'm referencing? Cortical controls of the respiratory rate. It's the outer few millimeters of your brain. So your medulla oblongata takes care of making sure that you're respirating, inspiring, expiring in the way that you're supposed to. But you can override that. If you want to hold your breath, your cortex, because that's a conscious decision, your cortex will allow you to hold your breath. And it will allow you to hold your breath until your oxygen levels get so low and your carbon dioxide levels get so high it causes you to faint. That's like your kill switch. Okay, so it will allow you to hold your breath, and then eventually whenever those levels get to a point where it's dangerous, it'll cause you to faint, and then immediately upon fainting you start breathing again. So that's your body's way of saying, tricked you. You thought you were going to get to hold your breath. A pulmonary irritant reflex. So you breathe in something that's irritated you, guess what you're about to do? Cough or sneeze. Cough, sneeze, choke. Yeah, it depends on what it is. But yes, if something irritated you, you're going to have a reflex to it. And that's what that's referencing. The Herring-Brewer reflex is talking about the fact that your lungs cannot overinflate. Unless, of course, it's forced air, and that's a type of torture. But you can only take in so much, and once they get so full, it's in a natural reflex. It's called the Herring-Brewer with capital letters, since it's not here, figured it out. It will force you to exhale. So it will only allow you to inhale so much. And it's just to protect your tissue. So this is showing you how all those controls are working together. And all of them are in blue, just so that you know. So it tells you that it's sensory information. Hyperpnea is where you are increasing your respiratory rate, probably because you need to. This might be because you're running, you're scared, you're exercising. So hyperpnea, hyper tells you it's higher, and we're talking about the respiratory rate. Respiratory adjustments for higher altitudes. As you start to move to a higher altitude, we already know that there's less oxygen available there. A lot of times, this causes people to get headaches, and they get really sleepy, car sick, motion sickness. So we talked about how the first days of vacation you should sleep until you can acclimate to it. But this is referencing that, getting that mountain sickness. Acclimatization is where you begin to become acclimated to that higher altitude, but the worst part about that is that it takes 2 or 3 days to do that, and then you usually leave on day 4 or 5 of that vacation. So unless you have this really long vacation, sometimes you feel sick the whole time. Do you remember what EPO does? EPO is erythropoietin, the production of red blood cells. So acclimatization, if we need more oxygen, we need more red blood cells. So it's mentioning EPO here. It's released from the kidneys to allow us to produce more red blood cells and therefore transport more oxygen. COPD, chronic obstructive pulmonary diseases or disorders. This is an umbrella name for anything that causes problems, obstructive problems in your pulmonary region. And chronic meaning that it's long-term. So this could be emphysema, this could be asthma, it mentions bronchitis. Overall, this is all irreversible. So a lot of people who have COPD end up carrying around oxygen machines. They have those little tanks that are pretty handy. But other common features of having COPD, you have, first of all, most of them are smokers. You don't have to be a smoker, but most of them are smokers. Dyspnea, which means that they have labored breathing, and you hear, like when they're breathing, it's like they're trying really hard to get oxygen from the air, but it's very difficult for them. They'll also have a really large thoracic area because these muscles are overworked, so you'll kind of see this like puffy chest because of that. They kind of stick a little bit more because it's more work for them to breathe. Ultimately, even though they're working really hard, they're hypoventilating, which means they're not getting enough. So tell me what they feel like. I'm tired. I'm fatigued. Hey doc, I am tired. So is everybody else. Homeostatic imbalances, when we talk about emphysema. Emphysema historically is caused by smoking, but we know now that emphysema can also be caused by atmospheric gases and pollution that are released. So we see people who've not touched a cigarette in their entire life being diagnosed with emphysema because of the pollution in the atmosphere around them. Usually in very busy cities like Dallas would of course be a good example, Chicago, New York. But ultimately the lung tissue loses its compliance, it's replaced with scar tissue, and no longer accommodates gas exchange. And so what does that do? It decreases my oxygen levels, my diaphragm becomes less active. Overall, I'm struggling to breathe. Bronchitis is an inflammation of the bronchi. When it's chronic, that tells you it's been taking place for a really long time. And I had a co-teacher this last year. I swear she had asthma attacks every single day. And her doctor was diagnosing her with something different, giving her medications for something different. And I told her, you need to leave that doctor because seriously what's happening is you just have bronchitis. And if you can get rid of that infection, this will stop happening. And she finally got into another doctor and they got her on some antibiotics. And a lot of times that all of this can be handled if you're looking towards the right causes in the right places. So her main problem was that she lived with a dog that shed a lot and she was allergic to that. So she had, it was a long process that we had to figure out in order to handle this. But chronic bronchitis, you have asthma attacks sometimes just on the spur of the moment. Walking up the stairs can send you to the hospital. And that's what was happening with this young lady. So frequent pulmonary infections, when you have those pulmonary infections, that's what you need those antibiotics for. If we can get rid of that infection, then we can allow for that inflammation to decrease and for airflow to occur. So how do you treat COPD? First of all, we classify our patients into two categories. We call them the pink puffers and the blue bloaters. And I know that this is horrible, but this is literally how you can classify them. The pink puffers seem to technically have pretty good blood perfusion, blood flow, and they tend to be taller and thinner. The blue bloaters tend to be shorter, stockier, and fatter, and the reason why they're bluer is because they're not getting enough oxygen. So they're either pink puffers or blue bloaters. And if you look at posters and literature on that, they literally have pink and blue people on there, like cyanotic, not blue, but you get what I'm saying. A lot of times when we have these issues, we use inhalers, which have bronchodilators, like albuterol or whatever it is. And that's another reason why not everybody can use the same inhaler because of allergies and inflammatory responses. So here's a diagram kind of showing you how COPD can take its course, but it gives you chronic bronchitis and emphysema as examples. Asthma is reversible COPD. You can grow into asthma and you can grow out of asthma. So you might have never had asthma before, and as an adult, you all of a sudden are asthmatic, and you could be asthmatic as a kid, and as you grow out of it. But it's a reversible type of COPD. Tuberculosis is a pulmonary disease caused by a bacteria that eats through your lung tissue, which is why you cough up blood. Because it's bacterial, you can get rid of it if you treat it early enough. But the course of antibiotics is literally at least a year. And that's just if you've been exposed. If you were actually active and tuberculosis, they found traces of it and they could do it with a chest x-ray, you're on antibiotics for 24 months. And if they see the blood, you go into, what is it when they keep you all by yourself? Quarantine, yes. Quarantine. There was a teacher in our district who had it, and she had to stay in the back room of her house, and she was on Facebook constantly, just, this is me by myself. I can't even hang out with my dog. Well, she started coughing, and the cough that she had was a very productive cough, but it was an unusual sound. Then they found out that where she worked out, someone had traveled and and then they treated the entire school and all the students and their families because she had been exposed to it and her cough had been so advanced. She had exposed the students, and the school district literally treated all of the students in that school and all of their parents and siblings. So it looked like one of those hazard type things. Lung cancer, different types of lung cancer, but this is just cancer within your lungs. Some are a little bit more aggressive than others, so it talks about the different types. And I know that I'm running out of time, but so you can kind of look through those. The big deal with any type of cancer is early detection of that. So making sure that you're going to the doctor, getting your x-rays and so on. If you do have cancer, we're going to treat it with radiation or chemotherapy. And that, I feel like most of our population knows that at this point. They are looking, and this was just actually links to our previous chapter, using different types of therapies, vaccinations to help vaccinate you against cancers that you could potentially. The thymus?
Thymus transplant.
Yes. But there's a lot of rejection on that too.
Is it?
Mm-hmm. But It's a type of therapy that they're looking at, and if you're on your last limb, let me try. Right? They're also looking at chimeras, where you're using genes from a healthy person and implanting them into somebody who is sick. Okay? Embryonic development, we know that the lungs are going to develop last. Look at you and your little lungs. Okay? You are so cute. By the 28th week, a premature baby can breathe on their own. Remember, the issue there is surfactant. And we want to make sure that that's being produced. Again, it will stimulate labor and delivery contractions when it's time. Gas exchange until the baby is born does happen through the placenta. Cystic fibrosis is where the mucus that's supposed to stay nice and runny gets hard and dried out. And now we know that what's causing that, and so we can give you an oral medication for it. But for a long time, people with cystic fibrosis would expire pretty early on in life, and some of them still do. But they're having trouble respirating because there's not enough whatever it is that I'm trying to think of right now. The respiratory membrane is dried out. I can't think of the word, but it needs to stay moistened. The lubricant, the surfactant lubricant, but it's the mucus that's drying it out and causing that difficulty in the breathing. Now I already mentioned we use pills to do this, but in the old days, like I had a kid in my second grade class who had cystic fibrosis, and they would beat on his chest, and he would be bruised all the time. Like it looked like he was an abused child, but at least 3 times a day, he would have to go through, I forget what they called it, but they would just palpate where they're just, and it wasn't like nice and easy. It was like bam, 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 because you're trying to loosen all of that on that poor kiddo. Now they have percussion vests that they can put on, and it kind of like shakes their whole chest and helps to loosen all that up. So again, you don't have that much bruising. As soon as you're born, we want you to inflate your lungs. We do that by asking you to cry or telling you to cry. With age, your respiratory efficiency decreases. Take care of yourself so that you stay healthy.